Welcome to the NWAETC Project Echo. I'm Kent Unruh, and I'd like to turn it over to Dr. David Spock to introduce our guest.
We're very fortunate today to have Dr. Randy Curtis, who I've worked with together for a number of years. And Randy is trained as a pulmonologist, but really has had a brilliant career doing a great deal of interesting research and clinical work around palliative care. And he's really been very innovative in the field and has been very involved in the HIV epidemic back really in the 1980s and early 1990s when we worked together over at the Madison Clinic. So he's going to talk to us today about communication about palliative care. And I think there's really no one really nationally who has had more experience and bigger impact than Randy has in this area. So we'll turn it over to him.
Great, thanks David. So what I thought I would do is just give an overview around palliative care, specifically focusing on communication and how we talk about palliative care. You know, it's interesting to me that when I was a resident, HIV/AIDS was a terminal illness, and palliative care was an enormous part of what we did in caring for patients with HIV and AIDS. It was up front and center, and I had an interest in palliative care. It's kind of what drew me to working in HIV and AIDS. And talking about palliative care was something that we did routinely with all our patients. With the tremendous advances that we've had in treating HIV/AIDS, it's really changed dramatically from a terminal illness to much more of a chronic illness. And what I've seen is that with that change, we've actually in some ways gone backwards. And by that I mean that I think it's harder to integrate communication about palliative care into the care of patients with HIV/AIDS than it was in the 1980s and 1990s. So, I appreciate the opportunity to talk about palliative care and how we talk about that. And most of the research I'm going to show is not focused specifically on HIV and AIDS, but I do think that HIV/AIDS has really become much more like other chronic diseases in how we talk about palliative care and our lack of ability to do that, frankly, in most healthcare systems. I think that one of the most important points around communicating about palliative care is a definitional point shown on this slide, and that is that it's really important that we conceptualize palliative care as being much more than just end-of-life care. End-of-life care is an important part of palliative care, but if we equate these two terms, we really miss the opportunity to introduce the concepts and the value of palliative care to patients with chronic but life-limiting illnesses. End-of-life care is care focused exclusively on patients who are actively dying or talking about the kind of care people want when they're actively dying. Palliative care is much broader, focused on improving communication about the goals of care, maximizing comfort and quality of life, and really ought to apply, by this definition, for any patient with either a life-limiting or a acute life-threatening illness. I also like to make the distinction between primary palliative care and specialty palliative care, particularly if you're going to use this broad definition of palliative care. Primary palliative care is the care provided by all clinicians caring for patients with serious illness. Specialty palliative care is care provided by palliative care specialists. And a big part, I think, of improving the quality of care that we deliver to patients with serious illness like HIV/AIDS is making sure that we support both sides of this. This is a cartoon from the New Yorker where a patient's in front of a doctor and the doctor says, "There's no easy way I can tell you this, so I'm sending you to someone who can." And that sort of captures, I think, this idea that this is not an okay model. It doesn't work to just say, anytime there's a palliative care issue, we're going to send you off to the palliative care specialist. And in fact, a lot of what we've been trying to do is to improve primary palliative care, to teach clinicians from primary care as well as many specialties how to talk about these issues. Palliative care really got an enormous boost nationally and internationally with this study. And it's not a study about HIV/AIDS, but I think it's a study that is really important in understanding what palliative care has to offer. This was a study for patients with metastatic non-small cell lung cancer who were randomized to either routine care at Massachusetts General Hospital, so pretty good oncologic care, or routine care plus early outpatient visit with a palliative care provider. And their results were quite impressive. They had a significant improvement in quality of life for the patients randomized to early palliative care. They had significant reductions in depression as measured by both the HADS-D and the PHQ-9, two depression indices. There was a reduction in anxiety as well, although that wasn't statistically significant. One of the things that this study found, which was surprising even to the investigators, was that those randomized to early palliative care actually survived longer than those randomized to routine care. And this was a clinically significant improvement. And in fact, this improvement outstripped the improvement that they were seeing at that time with any of the chemotherapeutic agents. And so the question is why? Why would you see an improvement in survival? And what is it that palliative care is offering these patients? What are these palliative care specialists doing? And it's not exactly clear, but what is clear is that patients who were randomized to palliative care were much more likely to talk about goals of care and were much less likely to receive chemotherapy in the last 2 weeks of life. And that may be the mechanism for improved survival in these patients. This palliative care consultation in this study was a bit of a black box. It was a palliative care specialist at Massachusetts General Hospital, not exactly clear what they were doing. But there was a follow-up study that I thought was very informative, where they did content analysis, qualitative analyses of the palliative care clinical notes on a randomly selected group of 20 patients who were randomized to the intervention. And this table shows the elements of the palliative care visits. And I show this to make the point that 6 out of the 7 elements were really about communication, relationship and rapport building, addressing coping, establishing illness understanding, discussing cancer treatments, end-of-life planning, and engaging family members really make communication front and center of what these palliative care specialists were providing. Addressing symptoms was also very important, and I think it did lead to reduction in symptoms. But it's pretty clear that a big piece of what palliative care specialists are offering is communication. And I think the question is then, okay, that's important. Is there a way that we can also improve that amongst the primary care providers and specialists in other areas? And we just finished a randomized controlled trial that was published in JAMA late last year of a communication skills building training program for residents and nurse practitioner students to try to see if we could improve the communication skills of these providers. We randomized over 350 internal medicine residents and over 50 nurse practitioner students to either usual education or being part of this intervention. And the intervention was pretty intensive. It involved 8 half-day sessions. There was interactive seminar presentations, but a lot of these sessions were focused on communication skills practice, using actors and actresses trained to be simulated patients or family members, and having the trainees get an opportunity to practice different techniques around communication, and specifically around communication about palliative care. We evaluated those randomized to the intervention to see if they did pick up new skills as part of the intervention, and we found that they did. This looks at some of the skills we looked at around giving bad news. The red shows the proportion of trainees who demonstrated that skill prior to the workshop. The blue is the proportion that demonstrated that skill after the workshop. In a standardized patient where their specific job was to give the patient bad news about recurrence of cancer. We looked at whether they assessed the patient's perceptions, whether they asked for an invitation to give bad news, whether they expressed empathy after the bad news, stated support throughout the patient's illness, and then whether they explored patient emotion that came up. And each of these significantly improved as a result of the workshop. We then compared the intervention to the control trainees by surveying patients and families that they cared for as part of their training, both before and after the intervention or the control period. And here we did not see a significant difference in patient ratings of quality of communication or quality of end-of-life care provided by the trainee. One of the things that we found, which is I think an interesting finding, was that there was a significant increase in depression symptoms amongst patients who were randomized to a trainee that was in the intervention. And so that was not what we were expecting. But I think it's an interesting finding and one that's important for us to take into account. It may be that activating trainees to talk about bad news, to talk about palliative care, could cause an increase in depressive symptoms amongst some patients. This is not a clinically significant increase in depression. We weren't inducing major depression, for example, but there may be some symptoms of the depression that come along with these discussions, particularly when done by trainees. We looked at subgroup analyses to see if we could find evidence of an intervention effect. We compared outpatients, looking only at outpatients. We had no improvement in communication. When we looked only at patients with the worst health status, who rated themselves as having poor health, then we did see a significant increase in their ratings of the trainees' communication skills. So this is a subgroup analysis. Overall, the trial was negative, but it gave us a signal, at least, that it may be that we were not focused on the right patients, and it may be that we saw benefit in the sickest patients. In summary then, from this randomized trial, the intervention clearly improved communication skills, and it also, I didn't show you these data, but it improved the residents' self-assessment of their ability to communicate. We didn't see an improvement in patient ratings, perhaps because it's difficult for untrained or unprompted patients and families to be sensitive raters, or perhaps because the care was provided by many clinicians and they weren't able to differentiate that. It's hard to know why. We did see a slight increase in depressive symptoms, which may be due to increased sense of sadness associated with having these conversations. Of note, that increase in depressive symptoms was most prominent for the first-year residents in the trial compared to the second and third-year residents. These are some of the tools that we use in communication, in teaching communication, and that we were able to show that we were able to impart. And I think that these are very helpful. These are just a couple of mnemonics, one for giving bad news, making sure we set up the information, assess the patient's perceptions, ask for an invitation to give bad news. And this is something that's awkward if you don't have a chance to practice it, but it really does allow patients to prepare themselves for the news you're about to give them. And I've never had a patient, if I asked, is it okay if I have some bad news for you, is it okay if I give it to you? I've never had a patient say, no, it's not okay. But what you see is you see them kind of tighten up, you see them sort of prepare themselves to hear this news and then relax a little bit, and it may be that that really helps them understand the information that you're giving them. The K is knowledge, making sure that you impart knowledge using simple language, express empathy, and then summarize and support. And similarly, for responding to emotion, we really focused on helping trainees name the emotion that they see. It seems like you're very upset today. Express understanding and respect for it, provide support, and then explicitly express empathy. And I think that these mnemonics, I think, can be very helpful for teaching communication, but I really do believe that you can't learn communication in a lecture format. It's a skill, and you have to be able to practice it, just like driving a car or putting in a central line. It's something that you have to be able to practice and get feedback on. So I think in terms of where we go from here, we're interested in finding more sensitive outcome measures. Since it did seem like the trainees learned new skills, we just couldn't demonstrate that at the patient level. We're also very interested in figuring out the best ways to integrate education into practice. We're in our teaching setting looking at using thinking of family conferences as a procedure that we teach just like we teach other procedures. We're also very interested in point of care tools, whether it be a smartphone app or a website where people can get quick teaching about advanced care planning and giving serious news at the point of care. I think that will also help our ability to disseminate this information. And then I wanted to finish up just by talking a little bit about the new Palliative Care Center of Excellence here at the University of Washington that was developed about 1.5 years ago. The mission of the center is to improve palliative care received by patients with serious illness and their families and provide support to clinicians. We also want to develop new knowledge and educational and clinical resources to improve palliative care regionally as well as nationally and globally. And we have a website that I'm showing here that gives information about things going on with the center, but also it will increasingly contain tools around education and clinical care. And you can also sign up as a member for free of the Palliative Care Center of Excellence to get information about events or tools that we're developing.